Hello, everyone, and good evening. Thank you for joining us today. My name is Gabrielle Mara. I work closely with Dr. Pulsatile. I am a coordinator for neurology and critical care at North Shore University Hospital and patient and family-centered care. It's a privilege that we have Dr. Athos Pulsatile today to help present at this Pulsatile Tinnitus webinar. I want to let you all know that I will be providing contact information for you if you do have any questions regarding this webinar and for support. My plan for perhaps in the fall, hopefully by September, I will also be having and hosting an emotional support group. So right now, Dr. Pulsatile is going to present on an educational forum, but we do know that it's very difficult to find support regarding this diagnosis. So I am a licensed social worker and I am here to support you all. So this would be a smaller group to discuss life with pulsatile tinnitus and how you're coping, and if you have any needs, and having that safe space for everyone to be available for support would be lovely. So if you're interested, I will also send out that email. So it's a separate email from the Pulsatile Tinnitus forum email that you guys have been connecting with us with. This one's a separate support group, which I will be putting on. So without further ado, I'm going to hand it over to Dr. Pulsatile.
Hi, everybody. Thank you for making the time to participate in this. And again, the purpose of these presentations is to educate patients and help them understand their conditions and take care of their own health. So today we're going to focus on venous sinus stenosis and venous sinus aneurysms in the context of pulsatile tinnitus. Judging from, actually starting from last month's webinar, where I broke down the causes of pulsatile tinnitus into vascular and non-vascular. And in the vascular group, which is the most common group, we had the arterial causes of pulsatile tinnitus, the venous causes, and the arteriovenous causes. Today, we're going to focus on the most common venous causes. And these are, in general, the most common causes of pulsatile tinnitus to begin with. The two causes we're going to discuss today is venous sinus stenosis, which is a narrowing of the large veins called the transverse and sigmoid venous sinuses. We're also going to talk about venous sinus aneurysms, which essentially are outpouchings of the veins close to the ear. The other venous causes are more rare, and I'm not going to discuss them today. I'm just going to focus on those two. Venous sinus stenosis refers to narrowing in the large veins of the brain. The large veins of the brain are called venous sinuses, and they include the superior sagittal sinus that goes from the frontal area to the back of the head and splits in the right and left transverse sinuses that continue as right and left sigmoid sinuses, which continue as right and left jugular veins in the neck. The stenosis is almost always, or at least most commonly, in the area at the junction between the transverse and sigmoid venous sinuses, which is close to the ear. On this graphic here, you're seeing the area of narrowing and the proximity to the ear system. Why does this lead to having pulsatile tinnitus? Under normal circumstances, any flow in a tube is what is called laminar. In other words, there is highest flow in the center and slowly, gradually getting lesser towards the edges of the tube. So a tube could be a vein in our body, or it could be any tube in everyday life that has any type of fluid flowing in it. When a narrowing happens, then instead of having this relatively equal flow across the width of the tube, or the width of the vein in this case, what we have is jet flow through the area of narrowing. Essentially, we have like projectile flow in the middle of the fluid in the middle of the vessel because of the severe narrowing. I think the best example from everyday life is when we pinch a garden hose and the water jets. This is basically what happens here. The blood jets in the area of narrowing and right after. This is what is causing the pulsatile tinnitus in patients with venous sinus stenosis, because this happens very close to the ear. And again, I'm showing the normal anatomy here. This is the normal transverse sigmoid sinus by the ear. This is, again, a graphic. This is the vein. This is the bone that encases the inner ear structures, and is usually like a 90-degree turn at this point. And when a narrowing happens, which is somewhere in this area, then instead of having this nice flow downstream, what you have is this projectile flow or high velocity flow right after the area of stenosis. Again, think of the pinched garden hose with this projectile flow. The same thing is happening in this area, which is very close to the ear system. And this is what we perceive as pulsatile tinnitus, this constant flow through these veins. Over time, because of this projectile flow at the edges of the vein, what happens is that the vein starts expanding. Just think of this, every heartbeat, there is projectile flow on the wall of the vein with every heartbeat, every second, every minute, every hour. So over time, the vein starts expanding. It thins the bone. The shaded area is bone, is the temporal bone that incorporates the ear. And over time, this expands and causes the vein to dilate. And this is how a venous aneurysm is formed. Venous aneurysm essentially means that the vein has expanded beyond its normal margins. When this happens, it enhances the transmission of the sound from the vein to the ear. And that's when many patients start feeling the pulsatile tinnitus more frequent, it becomes permanent, and it becomes more intense. It's very typical that I see a patient in the office and they tell me that I have pulsatile tinnitus. I could hear it only at night, or it was very quiet, or when I was exercising. But then over time, it started becoming like permanent. I hear it all the time and it's more intense. And the explanation is development of this abnormality, a second abnormality of the vein. We have the narrowing, and then we have this aneurysm that develops as a consequence of the narrowing. This is another graphic that shows the same thing. This is a vein. We have the narrowing, leads to turbulent, abnormal flow, slow expansion of the vein, and over time, this may happen. The vein may expand significantly and form a venous aneurysm that makes the sound even worse in terms of duration and in terms of intensity. This is an MRI scan that shows the same thing. The white area is the vein. Blood flow is this way. It's from the bottom of the picture to the top. And what we see here, the white arrow is pointing to an area of severe narrowing. And post the narrowing, this is the next picture. We have this outpouching of the vein. That is the venous aneurysm. Under normal circumstances, the vein should expand up to this point, but now it expands beyond and is forming this venous aneurysm. This is an angiogram showing the same thing. An angiogram means a catheter goes through the vein in the leg, into the vein in the head, into the superior sagittal sinus, and contrast is injected, and we see the contrast flowing from the head towards the neck. This is the area of severe narrowing. And after the narrowing, meaning in the direction of flow, we see this abnormal expansion of the vein that we call venous aneurysm. So this is as we see this on the MRI, and this is as we see this during the procedure when we do the angiogram. Something that I want to make very clear so I don't cause unnecessary anxiety is that these venous aneurysms or venous sinus aneurysms are different from the aneurysms that people die from. These aneurysms do not cause brain hemorrhage, do not cause stroke. The aneurysms that cause brain hemorrhage and stroke are the aneurysms that are related to arteries of the brain, whereas we're now discussing aneurysms that relate to the veins of the brain. And these aneurysms that are in the veins of the brain are benign. And again, they do not cause stroke. They do not cause hemorrhage. All they cause is pulsatile tinnitus. These venous sinus aneurysms can be most often associated with the stenosis, the narrowing of the venous sinuses, and I call them post-stenotic venous aneurysm, or they can be distinct and related to stenosis. This is not very frequent, but I see this in my practice. So you can have a venous aneurysm, an expansion of the vein, because the walls of the veins are weak and tend to expand, but unrelated to having a stenosis in the area. And you can have severe pulsatile tinnitus from this venous aneurysm as well, without the stenosis. As I said just a few minutes ago, the stenosis in the majority of patients is the initial event, is what is causing turbulent flow, and is the beginning of pulsatile tinnitus. With time, as this post-stenotic venous aneurysm develops, then the intensity and duration of the pulsatile tinnitus gets worse. So we have essentially two what we call synergistic mechanisms, two lesions that are related to the other, and the aneurysm makes the effect of stenosis in terms of causing pulsatile tinnitus worse. And treatment can be with stent alone if this venous aneurysm is not very large. There's a slight expansion of the vein. So one stent or two stents can cover the area of stenosis, as we see here. The red arrow is where the stenosis is, and cover also the area of the aneurysm. So you streamline the flow through the stent, avoiding, preventing this turbulent flow that hits on the wall of the vein. If the aneurysm develops to be something much bigger, like in this graphic here, the stent alone is not enough. You need to use the stent to open up the narrowing, streamline the flow in front of the aneurysm, but also you need to fill the aneurysm with something so that blood doesn't go in the aneurysm anymore. And that material is typically what we call coils in our specialty. They are soft platinum wires that we can direct through the stent into this venous aneurysm and occlude this sac that takes blood flow. So the idea of using the coils is that we essentially block blood flow into this aneurysm, which is how the sound is transmitted to the ear in these cases. So stent to streamline the flow and open up the stenosis, and coils to close off the flow into the aneurysm. The venous sinus stenosis can be associated with two major conditions. One is pulsatile tinnitus without any other significant symptoms. This is what I called a few years ago as isolated pulsatile tinnitus, which is distinct from the syndrome of high intracranial pressure, which is also associated with venous sinus stenosis. But in addition to pulsatile tinnitus, patients have like positional headaches, vision changes like blurry vision, loss of vision, or double vision, neck pain, and brain fogginess. Both are relatively common in the same age groups, young women. And um, often on the MRI, looking at an MRI scan or MRV scan, you cannot distinguish which patient has only pulsatile tinnitus versus a patient who has intracranial hypertension, unless you see a significant venous aneurysm, which is typically associated with the pulsatile tinnitus group only. The majority of patients, at least in my practice or in my clinic, that that present for pulsatile tinnitus evaluation, they do have pulsatile tinnitus from venous sinus stenosis. It could be that this is the norm in the population of pulsatile tinnitus. It could be because I get referred patients with this condition from all over the world, or it could be because many patients who are concerned that they have venous sinus stenosis seek out care with me. But it's the majority of patients that I see for pulsatile tinnitus do have venous sinus stenosis. This is a little technical in terms of the type of stenosis that we see in pulsatile tinnitus. In one of my webinars, when I talked about venous stenosis and intracranial hypertension, I spent a lot of time explaining the difference between intrinsic and extrinsic stenosis. The majority of patients with pulsatile tinnitus have intrinsic stenosis, means that there is a problem inside the vein that is causing the narrowing, as opposed pressure outside the vein collapsing the vein. So intrinsic stenosis means that the source of the narrowing is in the vein itself, and most commonly this is called by an arachnoid granulation or an old blood clot. I'd say 90% arachnoid granulation, 10% blood clot. Also, the venous sinus stenosis in the patients who only have pulsatile tinnitus is most often associated with venous sinus aneurysm than just stenosis. And then typically the patients with pulsatile tinnitus alone, they do not have positional headaches and they should not have papilledema. I always ask, when I see a patient with venous sinus stenosis, I ask them to see an ophthalmologist to exclude the papilledema, which essentially is swelling of the optic nerve at the level of the eye. I see, last year, I see many patients, they seek evaluation by ophthalmology on their own. And I think that's good, because one of the reasons that they enjoy interacting with the pulsatile tinnitus patients is because they are educated about their condition. They read, they learn, and they often drive their own care. So I see a lot of patients who go to the ophthalmologist on their own before I even get involved. So we talked about stenting as a treatment option for patients with pulsatile tinnitus and venous sinus stenosis. Who is a good candidate for stenting as a treatment option? And the one option is one criterion is the severity of stenosis. It should be at least 50% narrowing. I'd like to see 70%, to be honest. And it can be either bilateral or unilateral if one vein is much bigger than the other. Typically for pulsatile tinnitus is unilateral in the largest of the two veins of the right versus left transverse and sigmoid sinuses. This is most commonly seen for the patients with pulsatile tinnitus. In addition to the degree of stenosis, it's important to have at least a minimum pressure difference between the two sides of the narrowing. And this can be measured by a soft plastic tube, microcatheter, advanced in the vein and connected to equipment that measures pressure. And a 4 millimeter of mercury is the minimum difference, in my opinion, that should qualify somebody for venous sinus stenting. For the IIH group, the intracranial hypertension group, I use 8 as the cutoff because it's a little different disease. We're looking at different parameters, but for the isolated pulsatile tinnitus, I'm a little more liberal, and I accept 4 as a threshold of difference of pressure between one end of the narrowing and the other. How is the procedure done? How is the stenting procedure done? The patients need to be on blood thinners. Typically, we give 2 antiplatelet medications, aspirin, Plavix. We do, the first part is a catheter venogram and manometry, where we assess the severity of narrowing and the pressure difference, what is called the transstenotic gradient. And after this part is done, we proceed with stenting. The antiplatelet agents are important because whenever a fresh stent is placed in a blood vessel in the body, anywhere in the body, there is a risk of blood clot forming in the stent because it's a foreign body, especially in the early days of the stent placement. And so this is very important to have the blood thinners, the antiplatelet agents, and that risk decreases over time. There are many different ways to give these blood thinners, and the duration and the type of blood thinners. Let's say the last 12 years that I do these procedures, I start aspirin 5 to 7 days before and continue for a year after stenting. Sometimes I stop it at 6 months if pregnancy is in the works, or if there is like a medical reason to stop aspirin. That's quite rare. So most of the patients stay on aspirin for a year after stenting, and Plavix is only for 1 month after stenting. And this is my protocol, and I've been doing this for 12 years now, and I find this very effective. And I strongly believe that patients do not need to be on blood thinners for life for this type of stenting. Pregnancy should be avoided during the first few months because of the blood thinners and because of the, having had a procedure with anesthesia, but mostly because of the blood thinners. So I advise my patients to do that. And the first part of the procedure is done by a microcatheter insertion through a vein in the leg or a vein in the arm. And the microcatheter, this is how small these catheters are. Imagine like this is our fingertip and how small these catheters are. Think of a very thin pasta, like spaghetti, in terms of size. We navigate this into the large veins of the brain. We inject contrast to see the degree of narrowing, and all this is done under local anesthetic. It's not a painful procedure. These are the potential entry points, like in the arm or the leg. And this is what I see during the procedure. This is somebody's skull. You see the head looking in frontal. These are the orbits, the nasal area, and the skull. And this is a side view. You see this soft plastic tube that is advanced through the veins in the head. And this is when we inject the dye and we take pictures. We see very clearly the size of the veins, the area of narrowing here. You see the vein is being displaced a little bit, and the same here. So we know that this is area of narrowing, and then back to normal again. So a catheter from the groin or the arm all the way to the top of the head. Dye is injected from the tip of this catheter, which measures like a fraction of 1 millimeter. And this allows us to see the degree of narrowing. And then we make pressure measurements at different parts of the veins. The catheter is connected to a manometer or a special device that measures pressures, and we gently pull it back into different positions, and we record these positions. A transstenotic gradient is the pressure difference between this area, which is deeper in the head, as opposed to this area here, which is closer to the neck. So one side of the narrowing versus the other, we subtract them, and this is how we calculate the transstenotic gradient. And I said we use 4 as the general number for pulsatile tinnitus patients, and this number can be affected by the anesthesia, by certain medications, or even by a recent spinal tap. So we have to take all this into account. The most accurate measurements are done when the patient is completely awake or very lightly sedated, because then this anesthesia doesn't affect any of these numbers. The stenting requires general anesthesia because it can be painful. Even though it can be done with sedation, I avoid it. I think it's just too uncomfortable for the patients. And it can be done same day, like as just a continuation from the venogram, or on a separate day, and that depends on the discussion between the patient and the doctor. But generally for the pulsatile tinnitus, if I have confidence that the pulsatile tinnitus is caused by the narrowing, I plan to do the venogram and stenting on the same day. If I need to get a more detailed understanding of the blood flow before and then decide about stenting, I may do this on separate days. But for the most part, I do one procedure with part 1 as the venogram, part 2 as stenting. For the stenting, we do a second incision to look at the blood flow before and after the stenting, the general blood flow in the brain, and this is done through the radial artery in the wrist, which allows for easier recovery, especially for patients from far from our hospital who are going to fly a couple of days later back to their homes. This saves a lot of recovery time. The stents are these metallic mesh devices that are preloaded into soft plastic tubes, the microcatheters, and they are made from many different metals, but the majority of them include nickel and titanium. The more modern ones have chromium also, and there's some variation between different companies. This is how a stent looks like. It is a real stent from that we would use on a patient. And just to give you an idea of the size and the flexibility of the stents, how they take corners very nicely. Let's see if this video works. This is how a stent is in the patient's veins, and the stent is collapsed inside the catheter. That's how we advance it in position, and it's between this black dot and this black dot here. So when I press play, you will see the stent expanding from here all the way back. This is how we deliver the stent. Sometimes we need to put more than one stent, and I call this like telescoping, because one stent is a little bit inside the other to cause a continuum construct. So this would be one stent, and the second stent would overlap a little bit with the first one and extend beyond. And if we have to use a third stent, that's very unusual for pulsatile tinnitus patients, that the narrowing is so long that we need 3 stents. But that would be, again, overlapping with the previous stent, etc. So telescope stents allows us to have a longer construct for treatment as necessary. This is another example. You see the catheter placed in the head. You see the venogram. That's area of narrowing here. This is how an arachnoid granulation looks on the venogram. Is like this, almost like a mushroom protruding into the vein. Same here. Is like short, focal, and very discrete narrowing with round margins. And this is again like the deployment of the stent. Actually, the placement of the stent before deployment. The stent goes between this marker here and there. The narrowing is in this area here. And this is how the stent will deploy. Again, the maximum narrowing is in this area. So we have the stent from normal vein to normal vein, and see how this works. Slowly expanding, making sure it opens up nicely and it opposes the wall of the vein. And you see it expanded from here to here. We go back to the laser pointer. From here to here, here to here, and here to here. The vein was just in this area, open up, just was very narrowed at this point. And with the stent now, it opened up back to normal diameter, which is many times larger than what it used to be before the stent. This is before, this is after. You see, we don't see that mushroom filling defect anymore. Same here, the before, you see the filling defect, the narrowing, and on the post-stent, it looks completely normal. As I said many times in patients with venous sinus stenosis, there is an associated venous sinus aneurysm. This is how it looks. This is the angiogram from a patient. We see the vein. It gets very narrowed in this spot, and then it pouches out right after. Again, this is a more magnified view, area of narrowing. Remember, the blood flows this direction. This is a vein. The blood flow in a vein is from the head down to the neck. So the direction of flow is this way. So first we have the narrowing, and as a consequence of the narrowing, we have this outpouching of the vein, the venous aneurysm. So the treatment here needs to be twofold. One is to open a stent, place a stent to open up the narrowing and cover the area in front of the aneurysm. And the second objective is to fill the aneurysm with the platinum wires that we call coils. So this is the end result. Stents is actually 2 stents across the stenosis, across the opening of the aneurysm, and then through the stent, that's part of the same procedure. Through the stent, a small catheter will go into the aneurysm, and then we fill it with these platinum wires that we see as very black on the X-ray. So stent and coils. And this is the angiogram afterwards that you see. We have open up the narrowing, we have normal flow in the vein, and we don't have any flow into the venous aneurysm. Again, remember, this venous aneurysm is very close to the ear system, and by closing off the blood flow in the aneurysm, we block the transmission of sound to the ear system, and we resolve the pulsatile tinnitus. The post-procedure care is observation for 4 hours. Most patients will go home on the same day or to the hotel if they're out of state. And I reserve overnight admission if there is a bad headache or bad nausea. That's kind of unusual, but it happens. So most patients will go home after a 4-hour observation, and will be seen in the office soon if they're planning to return to their home out of state, or a couple of weeks later if they are local. And overnight admission only if there is bad headache that requires strong medications, or severe nausea that requires fluids and medications through the vein. Almost every patient has a post-stent headache, which is typically in the side of the head, from the eye to the back of the head, and that is almost always moderate, rarely severe, and rarely minimal. It improves daily. I give pain medications and steroids to most patients, and it resolves usually within 3-4 days, almost always within 7 days. Very rarely it will linger more than like a week or 10 days. It may, but that's like the 1 in 20 patients. And every day is better than the previous one. I recommend, because of the incisions, avoiding strenuous activities for a week, exercise, sex, lifting heavy objects. And in terms of being active, I encourage being active, but walking, I think, is the only type of outdoor activity that makes me, comfortable, for at least for the first few days. After the first 7 days, people can go to the gym and do their normal activities. In terms of going back to work, all the routine activities, I think a week, 10 days really is what is necessary, and that depends primarily on the severity of the headache after the procedure. Follow-up is, I should have said, a few days or 1 month, depending on local versus out of state. I see every patient at 1 month, or my nurse practitioner Kelly will see a patient at 1 month, and then we have a follow-up again at 1 year. Obviously, we'll talk to anyone who has any concerns in between, but these are the routine post-procedure follow-ups, 1 month and 1 year. And I get an MRV scan at 12 months, which is the time to stop the aspirin, and then again every 1 to 2 years. A study that I published a few months ago was basically focused on this topic, on stenosis causing isolated pulsatile tinnitus. This is, I think, the most important study I did in my career. And we had 42 patients that we excluded IIH. This study was done with under the approval of the FDA and the research board of our hospital. So it was very well designed and meticulous, and had a lot of detailed workup for the patients. And we excluded patients who had high pressure in the head. So this was isolated pulsatile tinnitus, and all patients were treated by me, and the results were that there were like 93% of patients, 39 out of 42, that had complete resolution of pulsatile tinnitus. Another 5% near complete resolution, so at least 90% improvement of pulsatile tinnitus. And one patient had 50% improvement because there was a second rare lesion of pulsatile tinnitus that I treated at the second time, and then the pulsatile tinnitus resolved after the second treatment. There was no serious complication, definitely no stroke or hemorrhage. We talked about the headaches that are pretty much universal, but I'm talking, in terms of serious complications like disability, stroke, death, need for emergency surgery. The risk was there was none of this. And my total experience in terms of pulsatile tinnitus and venous sinus stenosis is actually just more than 200 patients now, and it's a massive number for a single doctor in terms of treating this relatively rare condition. And out of these 202 patients, essentially 98%, this replicated the study in a real world scenario. 98% of patients had complete or near complete resolution of the pulsatile tinnitus. 30% of patients needed coiling of the venous aneurysm in addition to stenting. And I think that makes a big difference in terms of the results of pulsatile tinnitus. And there were few instances, I would say 4 or 5, I remember them, very, very clearly, that I needed to do bilateral stenting to achieve a good result. And that has to do with the fact that there were like significant narrowings bilaterally, both causing independently pulsatile tinnitus. And so that was, rarely necessary, but we need to to be able to identify these patients and treat them with bilateral stenting. And I'm very privileged that the rates of stroke, disability, of death in my series of patients is zero. So 0%. The risk is never zero of any procedure, and it cannot be predetermined to be zero. But my experience so far is zero, and so for this I'm very proud. So this is my experience up to last week. And I will finish this presentation by discussing something on the same lines, but relatively rare. A patient can have the venous aneurysm causing severe pulsatile tinnitus without underlying stenosis. And this is an example here. There is no stenosis in this vein, but there is this outpouching. This looks like a mushroom outpouching outside the vein. And the treatment would be to go in this area with a small catheter and fill it with coils so that blood does not flow into this and get transmitted to the ear. These can be seen in two areas. In the sigmoid venous sinus, which is where we see this now, in the proximal venous sinus close to the ear, or they can be seen in the jugular bulb, which is this area down here, where the vein from the skull, from the head, becomes a vein in the neck, the jugular vein. So where this turn occurs, there can be an outpouching, like a venous aneurysm in this area. Both of these are quite rare, but when recognized, can be treated safely and well. And this is the result of treatment here: coils in the venous aneurysm, and the angiogram after treatment shows normal flow into the vein and no flow into the aneurysm, as opposed to the pre-treatment where there's flow into the vein and blood flow into the aneurysm. So in summary, we talked about venous sinus stenosis as a common cause of pulsatile tinnitus. Unfortunately, it's underdiagnosed, and I see many patients who have the appropriate scans, but this was not picked up or not interpreted as a cause of pulsatile tinnitus. It's very common. I think it's the most common cause of pulsatile tinnitus in young women. My definition of young changes every year. Everyone who's younger than me is young, so that is a moving threshold. But in young women, it's by far the most common cause of pulsatile tinnitus. Also, we have venous sinus aneurysms that can be related to the venous sinus stenosis. That's a typo here. They should be associated with venous sinus stenosis, or they can be distinct, meaning without underlying venous sinus stenosis, like the example I just showed. And I want to stress this again: these venous sinus aneurysms are not the brain aneurysm that people die from. They do not cause hemorrhage or stroke, and the patients should not be concerned that something bad will happen to them because of the venous sinus aneurysm. It does cause the pulsatile tinnitus or makes the pulsatile tinnitus worse, but it will not result in a catastrophic hemorrhage or stroke. Both of these conditions can be treated safely and very effectively in expert hands. And I think as patients get educated and as doctors get educated about this, they will be identifying more of these patients and treating them earlier. And I'm finishing on a personal note. I want to show where I come from. I come from this tiny country called Cyprus, which is in the Eastern Mediterranean, and it's about 13-hour flight, and it's quite a long way, but I'm happy where I'm working, and I miss home, and It's a beautiful place, as you can see, with a lot of ancient history and medieval history, and nice seaside. And I try to go there every year. On that personal note, thank you for the time to watch this webinar. I hope you learned something new, or you learned something in more detail. And I look forward to the next one, which is going to be in September. And we're going to focus on a different cause of pulsatile tinnitus called dural arteriovenous fistula, which I think is also an underdiagnosed cause of pulsatile tinnitus.
Thank you. Thank you, Dr. Patsalides. So our next educational forum will be on September 9th, 6 p.m. Eastern Standard Time. We will be sending out those emails in the same Pulsatile Tinnitus forum at gmail.com. You all could see in the chat. Thank you all. We appreciate all of your positive comments in the chat room. You have a way to contact me. I manage both emails, so you will see usually me responding. If you have any questions, comments, concerns, please reach out to us. And if you would like to connect with Dr. Patsalides' office, I will also give you that information. Just shoot me an email. So thank you all very much, and we will see you next time. Be well, everyone. And we will also send out the link to this webinar. All right, everyone. Bye. Thank you all.
Good night.